Good afternoon and welcome to Population Health Connecting the Dots, a complimentary webinar from HealthSystemCIO.com sponsored by HealthGrid. Little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of HealthSystemCIO.com and I will be your moderator today. We encourage you to ask questions during the event. You can go ahead and type them into the Q&A box in the lower right-hand corner of your screen. Leave the default set to all panelists. Send them in as they occur to you. I'll hold on to them and we'll be asking them later in the program. You can download the deck using the URL on your screen. I sent it out in the chat box, and there's a shortened URL at the bottom of all our slides. And we are recording today's event, and you'll be able to view the archive. We'll post it to our YouTube channel just as soon as it's ready, and you'll get an email when it's up. Just so you see how we're going to spend our time today, we're going to go 45 to 50 minutes. First, we're going to hear from Ed McCallister, SVP and CIO at UPMC. Then we're going to hear from our sponsor, represented by Drew Vaughn, General Manager with HealthGrid. And then we're going to have our Q&A. So without any further delay, I'm going to turn it over to Ed McCallister. Ed, thanks for joining us today.
Thanks, Anthony. As Anthony said, I'm Ed McCallister, Senior Vice President, Chief Information Officer with UPMC. I've been with UPMC 16-plus years. I've been in the healthcare industry 25-plus years, and I can tell you that it's both an exciting and challenging time. It's an amazing opportunity as we move forward in transforming healthcare, and again, being 25 years in the industry, I can tell you there's never been a time like this before. We actually are at a juncture where the move to consumerism and population health are taking precedence over benefit plans and some of the traditional conversations we had around healthcare, and the payer-provider organizations are moving closer together by the day. And before I get started, I just want to share some critical thoughts and I think must-haves for success when we talk about population health. And they're critical, at least in the world of ed, and that's where we are today. So first, the IT business leaders must be aligned with the IT organization and the organization as a whole. I see my role as CIO as the technology leader, and my main assignment is to enable the UPMC strategic vision, some of which I'll share with you today. Next, big data discussion alone is not an extremely compelling story, but it is a great start, and we'll talk a little bit about that. Moving forward, consumer engagement will be critical as we transform into a more retail-based healthcare landscape, and you hear the comparisons of healthcare and retail more frequently today. I think what that means to me is we don't become Amazon, but rather we recognize the transformation the retail industry has made, and we take kind of the best experiences and some of the lessons learned, and we apply it to healthcare to create a new world. And finally, as it pertains to healthcare, cloud technology is both opportunistic and challenging, and again, more to come on this subject. So with this in mind, let's get started. So the agenda for today, who is UPMC? You may have seen us in some of the national publications, journalist Steve Brill's new book, or in Time Magazine. I'll cover a little bit about who we are. Again, at a very high level, UPMC's population health strategy, population health and analytics and how it ties back to the consumer, what you should prepare for when considering the move to the cloud, and finally, privacy and security considerations as they surround the cloud. I'm sure that we'll get into a bit of a cloud discussion and presentation a bit later, but I do think that there's an absolute necessity to pay attention to what's happening in that space. So some background on who we are. So UPMC is a $12 billion integrated global health enterprise headquartered in Pittsburgh, Pennsylvania. We're committed to developing and delivering life-changing medicine and are one of the leading health systems in the United States. And I believe we're the second largest integrated delivery and finance system in the country, behind Kaiser. With over 60,000 employees, we're also the largest non-governmental employer in Pennsylvania. I think we've surpassed Walmart. Our health services division, how we're structured is in the 4 divisions listed on the slide. Our health services division is comprised of more than 20 academic community hospitals and specialty hospitals and 400 outpatient sites. UPMC employs more than 3,600 physicians within the health services division. We also own an insurance services division, and there are over 2.8 million members within the insurance services division, 125 hospitals, and over 11,500 physicians. So if you tie the two together, you'll see that, Kaiser is a closed model IDFS, whereas UPMC, the difference with UPMC is we have the opportunity to have the closed model IDFS, but we also have our health system accepts many other payers, most other payers, about 99% of other payers, and our insurance services division actually has, whereas there's 20 hospitals as part of the UPMC enterprise, we have over 125 hospitals. So it's an interesting dynamic when you think about the integrated model, where we're integrated in some points and we're larger in the provider space when it comes to national payers, but we're also larger on the insurance side as far as our network. Also of interest, we've created what I would consider a very strategic, innovative division called UPMC Enterprises, which their goal is to pursue commercial opportunities and develop strategic partnerships with industry leaders. I partner closely with the enterprise team, their leadership team, and the way we think about it is if there's a need for technology solutions across the country or within UPMC, then that's probably a need outside of UPMC, and there are opportunities to spread what we've done at UPMC across the country through commercial opportunities. And, we have innovation centers. I consider myself an opportunity center, and the president of UPMC Enterprises and myself meet frequently, and we determine where the pain points are and what we can do in healthcare. And finally, we also have an international division where we export our expertise internationally. We're in more than a dozen other countries, and that area is expanding as well. So if you think about UPMC, we're here in Western Pennsylvania as a whole, but our footprint in Western Pennsylvania is very defined, but we're also doing things that are very non-traditional and outside of your traditional health system. So as I mentioned, it's important to align our information services division strategically across the business units and what I recognized on the previous slide. So who we are as an information services division at a glance. We have over 1,400 IT professionals supporting those 60,000 employees. We support over 100,000 total devices, PCs, mobile devices, printers, over 900 active software applications. So that's a very high number. And if you think about how UPMC has been built, it's been through acquisition, mergers, and other activities. So we're always aware that how do we consolidate, how do we actually manage the right footprint of applications, where are there redundancies, where can we become better in that space. We manage 8 petabyte of online storage. In addition, we have 16 petabyte offline, and we have 5 EMRs, which go across our inpatient, outpatient behavioral health settings and manage 2 data centers. So when we're talking about population health, you take into account 5 EMRs, 8 petabyte of storage, 935 apps, 20-plus hospitals, 3,600 docs, 2.8 million insurance members. It adds up to a pretty good starting point when we're talking about a big data discussion. And that's not to mention genomics, self-reported HRA data, and data collected through devices, et cetera. So hopefully that provides some background on who we are and how we are aligned. So as I mentioned, it's important to align our information services division, but at the same time, we want to recognize the challenges around healthcare reform and the broader movement toward value-based care and the need that's created as an organization to develop new competencies that traditionally, if you think traditionally what health systems have focused on, they were not part of our business models. I believe that UPMC, because of the background that I just described, is very well positioned and demonstrated the ability to enhance the health of individuals, as well as the overall well-being of the region through the IDFS model. And knowing that the IDFS model isn't necessarily the silver bullet or have-all, be-all, but I think, as we get into the presentation, I think you'll see the benefits of having the payer and provider side very closely aligned, which will enable population health strategies. And it's not without challenges, of course. And one glaring challenge is I'll just use the example of urban versus rural, which are very different populations and challenges. So on the rural side, if you think about 23% of U.S. population lives in rural areas, and nearly 20% of the rural population is over 65 years old. It actually creates some unique challenges to the rural population versus the urban population, which on the urban side, we're more likely to see large disparities in socioeconomic status, higher rates of crime, violence. We know that persons of lower socioeconomic status and minority populations are more likely to live in urban areas. Therefore, traditionally, they're more likely to lack health insurance as well. So the result of these populations face barriers to care. They receive poor quality of care and disproportionate use of the ERs. And I don't think we're unique in seeing the ER activities around the more urban populations. So how do we address these and the many other issues facing us today? You know, as I mentioned earlier, as a mature IDFS, we have a deep, holistic understanding of what it takes to provide and pay for care. At the end of the day, if you think about there's only $1 to spend, and how that dollar is spent is where I believe we're having all of the pieces to the puzzle, or, you know, as the presentation states, many of the dots that need to be connected. It results in the ability to create a different model of care. So our strategy and how we've been able to leverage the benefits of being both payer and provider has been to create a very broad, data-rich, horizontal record for our entire population. So if you think about what that means, I've covered a lot of the different systems, the different landscape within UPMC. We have an opportunity with our data sources. Traditionally, payers have been ahead of the curve when it comes to data warehousing because they're dealing in a very much a structured data world. When you get into unstructured data, which it resides more on the clinical side, it becomes a different challenge. So I think as CIO of UPMC, within the UPMC organization, it's a challenge, but it's also a great opportunity to leverage what we've done on the payer side in the data warehousing space, and how we create a federated model to reach over to the provider side as well, and tie the data together to create this horizontal record that it doesn't necessarily go very deep, but it's extremely broad. So I'll talk about what that means when we get to the deeper analytics discussion. But I think as a starting point, we know a lot. We know a little about a lot of people, and that horizontal record is the starting point for us. So UPMC's approach to population health. UPMC, we put the consumer of healthcare in the middle and leverage the trust between patient and provider during the engagement. And what I mean by that is, although payers have been in the population management space for a while, and I'll include us as a payer, I think we do an excellent job within our insurance services division. We've scored very low. The insurance industry has scored very low on the trust meter, whereas the relationship with the clinician rates very high in trust. So what we've tried to do at UPMC is take the great work that's been done on the analytics side through population health, through understanding the consumer needs, and through payer-provider collaboration, creating the story so that the provider, who is the trusted source for the person, can be the deliverer of the message, and you put the provider in the middle with the patient. And what that creates is the right engagement, one point of contact, multiple outreach methods matched to that specific member. And in box 5 on the slide, you'll see the aligned network. And when I say the aligned network, it's really our care team, including pharmacy, some of the strategic relationships we have with the caregivers, along with our great cast of providers as well. So population health and analytics. Our approach relies on big data. I mentioned earlier that it's really not the story. I think that we do a great job. Big data is one of those terms that I think is bantered around, and different people have different ideas as to what big data means to them. I think that UPMC has the opportunity, and we've taken great strides to create a big data environment, but big data alone is just one part of, I think, what I'd call the three-legged stool, and it's really tying the enterprise data warehouse and the technology team in with our data governance team, which we've actually built out at UPMC, and they've been recognized nationally for awards on how we do data governance. And then the third leg of the stool would be the analytics team. And we, on the clinical side, again, we're at different phases in the process, but the Enterprise Analytics Initiative is born to tie them together. As we move forward on the Clinical Data Warehousing Initiative, you have the Enterprise Data Warehouse, you have the Data Governance Team, and then our Vice President of Clinical Analytics, which is a newly formed position, tied together, and together I think that's where the power comes from. So we've actually at UPMC invested heavily in all of these areas. For example, we're in about the third year of a 5-year, $100 million enterprise analytics initiative. As we continue into year 3, we've been able to refine the process, build the foundation for success through the partnership of those 3, wrap the UPMC strategic vision and the outstanding clinical minds into the mix, and I think it creates a great foundation for great population health strategies. So this slide, it just gives some unique enablers at the bottom of the screen and some of the different data sources and what you can do with the different data sources. So again, it ties back to big data alone doesn't really matter, but if you align the data with what you're trying to do and some of the activities around what you're trying to provide, I think that's the real story. So the bottom box, which represents the data, in the middle as far as the green boxes, which represent the activities, are nothing without the health economics analytics team that sits above them. So on our health plan side, when I talk about our investment in analytics, we have a 28-person team of medical statisticians, epidemiologists, and generally very smart people that can take the information and make it more meaningful than it is as standalone data. I'll give you an example of why I like this slide. Our chief analytics officer with the insurance services division used to tell the story and use a different slide, and there was a coal miner at the bottom left of the slide, and it looked a lot like me. And at the top right-hand corner of the slide, there was a diamond and a person that looked a lot like her. And the story was that she took information, she took the coal and transformed it into a diamond. So I like my slide much better, but you get the idea of what we're able to do together, how you start with the foundation of data, run it through some of the very detailed deep analytics models and have the brain sitting above the pyramid. So I talked about how UPMC is unique as an integrated delivery system, and once you're able to create that data platform and develop the strong governance around the data, combined with our brilliant clinicians and their vision of patient care, because that's kind of a secret sauce that many leave out of the mix. I think if you separate technology, analytics, and these other IT technology strategies away from the real story, which is what UPMC excels in, excellence in care, you add in the equation the depth of knowledge and experience that our health plan brings to population health, and again, we're very well positioned to impact our stakeholders. You see the payers at the bottom of the slide. Again, if I'm Ed McCallister, I could be at any given time an Aetna member or a Cigna or a UPMC health plan member, which would be my preference, by the way, and I could bounce around the clinicians, but as the data, and you have your advanced analytics on the right hand of the screen, you're creating a federated experience across all of the environments, so it becomes a very personal experience. And what that means is it shouldn't matter. You shouldn't start from the beginning just because you move either payers or to a new doc, but rather capture that information in the cloud that surrounds the individual and keep that patient/consumer in the middle of everything we do and how we think about it. So as an aside, I don't want to get too deep into a consumer discussion, but how you interact with that person should be driven by that person. So it's a different meeting, and I think it'll probably be another half hour, but true success is really allowing the consumer to define what a great consumer experience is, and tying that information into a great consumer experience is what we try to do. So population health and the consumer, again, you put the consumer in the middle, you see the cost, quality, access grid, just different words, living by different words, but it's all driven through analytics. I think that if you start with a story of the data, our analytics executives talk about it often. You don't really tell the story that you want to tell and try to find the data, but rather have the data tell the story. And I think this slide is actually a good one to show how it fits together, the analytics wrap around, and what the benefits of this approach are as well. So now we have the data. We've touched on the analytics and how we're tying the pieces together using the great clinical minds. And in order to manage this, obviously it doesn't happen magically, and there aren't databases that we just, the data automatically appears from. We had the analytics. And so about 2007, we looked for a platform that could potentially, manage this information, some of the great work in the analytics world, and we just couldn't find one. They were all very disease-centric. So we moved to developing a platform called Health Planet, which is custom designed, member-focused. When we were looking, it was very disease-centric. So as Ed McCallister, if I had 3 conditions, I was in 3 different databases. There were actually 3 outreach methodologies around me, and it became very confusing to the consumer. So we developed this Health Planet platform. What it allows for is a very strong workflow engine and integration with all of our hospitals, physician offices, and it extends and it ties, it bridges the gap between payer and provider. So this is the network that I mentioned earlier as far as how we try to tie the experience together. So Mary in the center of the diagram, regardless of her care or her condition, she has the right people that she's interacting with. And it's not a matter of multiple outreaches. So you see the globe around Mary. We know the right person through the workflow engine and how we want to reach out to that person. So basically, the Health Planet platform aligns this team on a common technology platform, powerful workflow engine. And what this does is it allows our UPMC care team to manage and improve the health across the full spectrum of populations. If you think about it both at the individual and group level, allowing for bidirectional data exchanges, and again, I'll show on the next slide how that works, and a consumption of data at its source, ability to assign the task, and such. So this is probably the best slide to get a clear picture of how the information flows in a bidirectional way. So you start with the many data sources at the bottom. You layer the analytics engine workflow, or analytics engine on top of it, and it creates the workflow, feeds into the workflow engine, and assigns the right care at the right time because it is very member-centric. And also it's a learning model. So as we learn more about the consumer, it feeds back through the analytics engine and into the appropriate databases. And again, the result, each member receives a unique, personalized, quality-driven experience. It's part of a comprehensive population health approach. Every slide that you'll see has the consumer in the center. I think that's a key to what we're trying to do. It can't be a disjointed experience or you lose confidence. There's 2 pieces to the population health piece, obviously, is what we do as a health system and a health care organization around population health, but again, without forgetting that it's the consumer that matters through the process. You may have heard of the Pittsburgh Health Data Alliance. And again, you read some of the quotes, but really in addition to all of the other things, we've engaged with UPMC, Carnegie Mellon, and Pitt, and we have an initiative called the Pittsburgh Health Data Alliance. And when you combine Pitt with its expertise and excellent track record in research, and Carnegie Mellon, who's recognized basically as a world-class computer science and machine learning institution, and the brilliant minds, technology, data resources within UPMC, I believe will accelerate the goals that encompass all that we've talked about related to population health, and it'll allow us to be more exact and precise in creating solutions moving into the future. And this initiative is being led by our UPMC Enterprises team that I mentioned earlier. I truly expect that there are amazing solutions to be born out of this partnership, and I personally believe that this partnership will transform healthcare. Very exciting times. So the move to the cloud, and I'll touch on these because it's really, I think, important to understand. If you really want to get into a great technology debate, the cloud's the place to be. So in a recent publication, Tony Scott, who is the U.S. federal government CIO, said that big cloud providers are just as secure as today's largest financial institutions, and advises his fellow IT leaders to embrace cloud sooner rather than later. Well, I read the comments that followed the article, and they were probably split down the middle. Bottom line is there's absolute value in cloud technologies and move to the cloud in some form, which we at UPMC have embraced. our strategy is to move many of the commodity services to the cloud so that we can invest in the more strategic initiatives. Example, we're moving to Office 365 with Microsoft, and in addition to the efficiencies gained through, or the cost efficiencies gained through the move to the cloud, it's actually the functional efficiencies that are more interesting and what we're excited about. So again, bring up the cloud to some of your IT colleagues. I think you'll hear the latest article they read, and that'll be the opinion, I believe. So if you walk through pros and cons of what we could do or couldn't do, like scalability, and the more current term is elasticity. You know, it's the ability to flex up and down. How do we want to do it? So the pros, the cloud gives you much more flexibility and a much more nimble approach. I won't read the rest to you, but those are what I'd see as the major pros. On the con side, the first one, costly. It's only costly if pre-existing investments are taken into account. So if you're rolling out new solutions to the cloud, I'd argue that they're actually more cost-effective. So again, pros and cons. I think that they could apply accurately to your organizations, but I think in general they kind of capture what the general thinking is. We can't do a presentation without privacy and security. What I've seen is, at least compared to other industries, healthcare has been slow to adopt a move to the cloud, mainly due to the sensitive and private nature of healthcare data, as we know. We all know that, I mean, we read that PHI is much more valuable than credit card data on the black market, increasing risk of data breaches. Healthcare has been slow to adopt to the cloud because of these reasons. And I have a few examples listed on the slide, but quite frankly, they could be any of us. I mean, they could be anybody. So I think what you have to know in this space, it's no different than the way we address security in a more traditional way. I think that it's important not to get too hung up on security in the cloud because, again, when you're in that debate with your fellow IT colleagues, I could support in some fashion that cloud security is. I wouldn't argue with our with the statement that I made earlier that from Mr. Scott. So if we talk about privacy and security, and while we've been slow to adopt the cloud, I think statistics show, and I'm certainly in this camp, that the pace is going to rapidly increase. However, what shouldn't happen actually is without continued increase in investing in security as we have done today. You know, so I listed some areas. You know, secure data transfers, interfaces, secure data storage, user access controls, and data separation. But you know, that said, you know, this shouldn't be new as we manage today's security concerns, both on and off premise. And you know, along with the controls that I mentioned, some of the areas that we're focused in are user education and awareness on a list of much do's. I'll give you an example. We're doing phishing simulations and phishing exercises as related to our employee population. So we started with the IT organization, and we had some phishing exercises where we put our own employees through the exercise of some malware-like emails that we sent, and there was too high a percentage of people that fell for it as part of IT organizations. So we're rolling that out across the entire company. It's relatively inexpensive and extremely effective, I think. So in summary, just some bullets. I think population health relies on access to big data, but not big data alone. UPMC, we're developing a federated data warehouse to enable the comprehensive data analytics enterprises, as we talked about, and with that, we'll build onto our population health strategies. And with the rise of consumerism, healthcare is becoming more patient-centered and data-driven, and I believe technology will enable this transition. And the cloud is a great enabler of consumer experience when it comes to data and user experience, and we shouldn't get hung up on the uncertainty and the unknown of it. And although there are some risks, I think that in this world we're facing risks every day. It's just another, and it's not necessarily the risk, but how we address the risk and prepare for it. And finally, ensure a strong focus on security when considering the cloud. So I'll end with my friend Albert, and who says, you know, we cannot solve our problems with the same thinking we used when we created them. I can tell you that technology is moving at a speed that I personally have never experienced, and while making a strong effort to keep up is great, I think that we'll all be judged by our results. And again, I opened the presentation with the fact that it's a very challenging yet exciting time, and I think, as you walk through the opportunities we have within not only the healthcare industry, mainly the healthcare industry, but from a technology vantage point and how it applies to the healthcare industry, I think that the sky's the limit, and we've only scratched the surface. So with that, I'll close, and thank you very much for joining me on the webinar today, and I believe we'll have questions at the end, right, Anthony?
Yep, that's right. Well, thank you very much, Ed. Great presentation, and we're looking forward to your Q&A in a few minutes. First, we're going to hear from our sponsor, represented by Drew Vaughn, General Manager with HealthGrid. So, Drew, thanks for joining us. Thanks for sponsoring today.
Thanks, Anthony. Yeah, first and foremost, congratulations to Ed. UPMC has always been a clear thought leader in the industry, and a lot of great content in the deck today. Second off, thanks to Health Systems CIO for the opportunity to sponsor the event. A couple quick words about HealthGrid. HealthGrid is working to really transform the way, as Ed was alluding to, that health systems interact and activate their patients in their care. We've really created and worked to create a mobile CRM platform, patient engagement platform, if you will, that leverages cloud-based push web solutions to provide very simple, actionable campaigns to many of our health system clients, which really work to engage patients across any device, anytime, anywhere. And we do that through a number of ambulatory as well as acute care and post-acute care workflows. From a mobile perspective, we know that the healthcare industry is transforming at a crazy speed. The adoption of mobile phones provides us a great opportunity to activate and engage with our patients like never before. Just about every patient today, 89% of patients today, have a mobile device that they carry with them everywhere that they go. In addition to that, not only do they have mobile phones and smartphones now, but we're seeing that responses to messages directly to their phones far surpass the ability to contact them through phone call outreach and even through email or the patient portal or downloading applications to their own device. So by leveraging the power of mobile, leveraging the power of text messaging, we really have a great opportunity to connect with our patients in a very convenient way to them. In addition to that, in conjunction with that, I should say, we've seen that SMS technology is actually the optimal compliance platform for at-risk populations. Both low-income groups respond to SMS text messages more often than any other medium. In addition, low education levels send and receive more text messages per day than any other demographic. So we really see the opportunity as we're trying to control costs as many stakeholders across the system, the optimal way to work to engage patients. What we've put together here at HealthGrid is really a platform that's focused on delivering a world-class patient experience in conjunction with helping our systems march to the business drivers and the value drivers that reduce costs across their own operational organizations, et cetera. The way that we've really architected our solution is we put together really a comprehensive care continuum platform that starts with a simple outreach to a patient, as an example, in an ambulatory setting for an outstanding service that they may be due for based on their condition. And through that process, we continue to engage and activate those patients at many touch points within where they are in their care journey. So as an example, as I'm displaying on the screen here, we may send an initial text message to activate the patient. In conjunction with that, we actually can check them in and allow them to check in on their own devices. We provide them with pre-service education so that they can actually prepare for their visit with their providers or the services that they're coming in for. In conjunction with that, we provide them with a number of opportunities to engage with their family members, et cetera, at the point of care by providing up-to-date alerts. And then most importantly, post-care, We're providing them with discharge instructions via their mobile phone, educational content related to their meds and their problems, and performing very specific follow-up based on the care plans that their providers have set for them to really make sure that we're driving value to patients, keeping them connected, but at the same time driving value to our customers who are health systems. The way that we've architected our solution is we've really put together these multiple experiences or these multiple use cases for the patient into very specific modules, pre-care, point-of-care, and post-care. And we have the ability to do anything from gap and care outreach, real-time appointment scheduling to mobile check-in, all the way through to very specific patient family notifications, discharge preparation, and last but not least, post-care, as I was alluding to, ensuring that they're connected to their downstream providers through referral management solutions and providing them with the key information that they need post-care to ensure adherence to their care plans. We found that, again, kind of touching on some of the statements I mentioned earlier, the most easy way for a patient to engage is to have information pushed to them in the right time, in the right place, in the context of where they are in their care journey. And so the patient, through our system, does not need to download an application. They do not need to do anything. They receive text messages from their care providers and from the system at specific points in time where they're able to actually click on a link on their mobile phone, authenticate using their last name and date of birth, and basically once they've done that process, they would basically land on any of the campaigns or use cases that I was alluding to. So very secure platform. It's a two-factor authentication. We're not only ensuring that that specific link is sent to that specific cell phone, but we're also providing the ability for that patient to authenticate with who they are to see the appropriate campaign that the health system wants to execute. So that's essentially how our platform works at a very high level. We work with a number of health systems across the country, CHS, HCA, and Tenet, and are very excited to be bringing this mobile CRM solution to market to help transform the way, as I mentioned earlier, to help transform the way health systems really connect and engage with their patients. So that's a little bit about HealthGrid and who we are. Anthony, I'll go ahead and turn it over back to you.
Very good, Drew. Well, thank you again for sponsoring, and thanks for delivering that message. So now we have time for Q&A. So as I mentioned, go ahead and send in your questions in the Q&A box. Leave the default set to all panelists, and I will take a look at those and pose them to our speakers. Ed, first thing I want to come to you. I'd like you to talk a little bit about the model that you've got as a health system where you described it as an IDFS, but it's not the same as Kaiser. So they're kind of closed and you're closed but open. Talk to me about that unique model where you've got your own, you're insuring populations, but you're also seeing patients that are insured by private payers. Does that make your work in population health a little more complicated, or does it give you more opportunities to do different things?
I view it as an opportunity to do different things. If you think about this, so you have different sources, so it's not all one size fits all. So we can do some analytics around what does it look like when a person's a health plan member but not a UPMC patient, and what's it look like when a person is a UPMC patient and not a health plan member. So I think the dynamics and the different lenses from which you view the population are more dynamic, and therefore I think, again, the data tells a different story than it would tell if you were a member of the health plan and health system. Not that that's not powerful data, Anthony, but I think that it's a different dynamic when you don't have it all in one bucket, but rather you have that horizontal record that I mentioned earlier, and you know a little about a lot of people versus a lot about the same group of people.
Mm-hmm. Let's talk a little bit about compliance, because at the core of everything we're doing here with the move to value-based care and population health, we need to get patients to take on healthier behaviors and to be committed to following what they're supposed to be doing from a medication point of view and these type of things. And the HealthGrid is one platform that allows people to engage patients to get them to do these things. Ed, how far does this go? How far can you go into the patient's life? You know, you talk about economic incentives. So you've got these engagement, you've got incentives, and then you hit socioeconomic issues. How far do we go to incentivize this behavior that we need as health systems to be financially successful?
So I think it's a great question. I think it varies by population. I think that's where the stratification comes into play. So we stratify our entire population, and we have them in buckets of, who's ready to change and the different phases of change. I mean, Drew, brought up a good point in this one slide where they have the pre-care, point-of-care, post-care model. But how do you get to the pre-care for somebody that doesn't recognize that they even need care, right? So I'll give you an example of what we're doing at UPMC. I mentioned it where it's good because we're kind of a living laboratory. We have the pieces. So I'll use our 60,000 employee population as an example. We have UPMC Health Plan as our payer. And we have a program within the health plan in the wellness division called Take a Healthy Step. And the UPMC Health Plan works with UPMC as an employer group in a certain way. And we've been able to attain in the high 90s, 93, 94, 95% compliance with taking a healthy step to change your behavior. The point you bring up earlier, there was a good one. How far do you go? I think that when Drew brought the point up, push to the consumer, I think that you need to engage the consumer at the point of which the consumer wants to be engaged. It's definitely not a one-size-fits-all. For instance, if text message is your preference, you communicate with that consumer, the population, through text messaging. But if they're used to a telephone, and that's the best way to reach them, you can't be afraid of old technology either. So I think it's aligning the population with the opportunities that we have through technology to change behavior, knowing that, we're not going to change necessarily 100% of the population overnight, but as long as we're moving in that direction, I think it's the right model.
Could you see this getting to the point where you're responsible for a geographic population and what they need are certain things in the community you talk about socioeconomic things, you get into politics here. What they need are certain things in the community, resources that enable them to become a healthier group of people. It could be supermarkets or different care centers or things like that. I mean, eventually, if you're on the hook for the health of this population, you may have to go outside the box and get more into the political realm. Is that where this is all going?
Well, I'm not sure about the political realm, but I think that's the model of ACOs and what it means in working with the provider community and providers going at risk for a certain population. The reimbursement model's just been flipped on its side. If you go back, a short, and there's still a lot of fee-for-service even in this region, but if you go back just a short period of time, the model was more to be paid for widget production. So if you're paid for widget production, you're going to create a lot of widgets and a lot of revenue. I think with the CMS reimbursement changes, I think that's what's going to actually drive it. I think that the partnership and having the providers kind of take control of the population. I mentioned on the one slide that they're the trusted source when it comes to changing behavior and communicating, what's best for the patient. I think as we get more into that model, as the reimbursement rules change and more, I think that's what's going to do it. Obviously, we're very involved in the community, and it's important. The politicians, obviously, they have a very strong voice in some of the communities, but I think we've worked well with them in that space to date, and we'll continue to.
Okay, great. Next question. What is the role for what kind of people do you need to throw behind this? So we talk about a lot of case managers. Give the folks who are listening some idea of the human factor versus the technology factor. Obviously, the technology is what's going to scale, but there's a certain amount of individuals that you need managing this population health and sort of driving these technologies towards these people. Tell me your thoughts on that.
Yeah, so I think the vision has to start at the top, and here at UPMC it does. And we've been through recent restructuring where we flattened the organization in a way where the hospital division and the physician division became the health services division. So I think a flattening of the organization, our leadership at the levels of the slide that I shared is our alignment with health services division, insurance services division, international, and our enterprises division. They are in lockstep. So that's where it starts, I think. And from there you build teams. And they can't be team siloed within each of those divisions. So they're really cross-functional teams where, one of the most important meetings that take place here at UPMC today are the payer-provider meetings, where you have executives from both sides at the table and talking about how do we do this. So I think it's, when you talk about the people, I'd go on for hours talking about the different skill sets. I mentioned our health economics group, very talented group of people. Our IT team is extremely talented. Our clinical minds that we have here are fantastic, but alone they're not nearly as powerful as they are when we take our senior team gets together and they create these teams of people that traditionally may have resided on the payer side or traditionally on the hospital or physician side, but instead create a new team for the new problems that we're trying to solve.
Let's talk a little bit about your central data warehouse. Is this, and we've done some events where we've talked to people about data management, data warehousing. Are you a Hadoop fan? And that's way out of my depth, but I know that's been touted as something that's very effective.
Yeah, I'll tell you, we're vendor agnostic and product agnostic. It's what works. Whatever works, we absolutely are tied in, and we actually do have we actually do use Hadoop, but again, that's one that's one avenue. I think when I mentioned the 5-year $100 million investment we have within enterprise analytics, and I tried to make the point, but what's critical is to understand we call it enterprise analytics. There are so many components to that, and you don't start with the analytics, but rather the data, and that's where the Hadoops and the some of the other, I don't want to start rattling off all the vendors.
No, that's fine. That's fine.
But that's where I think you start with the problem, and then the solutions and vendor solutions that are out there. I think you apply them to the problem you're trying to solve, versus being the proverbial Band-Aid looking for a cut, which we would be if we started with the technology.
Very good. Excellent. Well, Ed, I think that is about all we had time for today. I want to thank you so much for joining us and delivering the great presentation. I want to thank our sponsor, represented by Drew Vaughn, that would be HealthGrid, for making today's event possible. As I mentioned, you'll receive an email when our archive recording has been posted to our YouTube channel. There's the shortened URL of our YouTube channel. We'll get that up within the next business day or so. For those of you who have the CHIME CHCIO certification, attending our webinars gets you 1 CEU. So go ahead and let CHIME know if you've attended, and if you've asked us to let CHIME know, we will. Sponsorship opportunities, you can contact Nancy Wilcox. Questions and comments, you can reach me. And you can go to our website to view our upcoming schedule. So again, I want to thank Ed, Drew, and HealthGrid, and everybody have a wonderful day.